Now, as I promised, we have kept the best for the last. We have Dr. Camilla Rodrigues, who's head Department of Laboratory Medicine and consultant microbiologist, chair of infection prevention control in Hinduja Hospital. She's an internationally known microbiologist, one of the best in India, and I would not stand between her and you. I thank you all for being with us and for Dr. Camilla Rodrigues for staying so late with us. Thank you very much, Dr. Rodrigues. Please, the floor is all yours.
Thank you, Dr. Rattan, and thank you, all of you delegates, for staying on. I promise to be done in 10 minutes because I know you're tired and dinner's waiting. So I'm going to speak on a slightly different aspect of NTM, and this is clinical and lab aspects of rapidly growing mycobacteria. Next slide. And this is the outline of my talk. Next slide. And as you've all heard, the 4 types of NTM disease, I'm going to speak on NTM inoculation disease. Next slide. And not the inoculation that comes from the environment. I'm actually going to speak on the inoculation disease can be skin infection, trauma, soil, catheter related. I'm actually going to talk on post-surgical nosocomial infection. That to me is the elephant in the room. India, this is one of our biggest problems because we are seeing a lot of surgical nosocomial infections with rapidly growing mycobacteria. Next slide. Yeah, I'm going to take you back to 32 years ago, or maybe was it 32? Yeah, 1994. Our surgeons in a private hospital in Mumbai had gone abroad and learned the latest techniques in laparoscopic surgery. They came back with fancy laparoscopic equipment. They didn't involve infection control, and they started doing surgeries. And imagine in 1994, we had 33 patients who presented over 4 months with port site infections. And as you can see, this is where the laparoscopic port goes. Next slide. And the gram stain didn't show organisms, but when we did the AFP smear, we found lots of these kind of organisms in bunches, which we knew wasn't MTB. When we looked at where these were coming from, we found that the trocar and cannula, these are single-use devices that are meant for a single use only. But remember, in India, because the costs are so high, we tend to reuse single-use devices. So the trocar and cannula, without our knowledge, in the OT, was being put into a soak jar, as you can see here, 2% glutaraldehyde soak jar. The likely source we felt was tap water. Next slide. And when we looked at the glutaraldehyde, you can see the tray there. We actually recultured Mycobacterium cheloni from the soap trays, and we also grew it, not only from the patient samples, but also from the soap trays with very high MICs to glutaraldehyde. This was the first reported case series of laparoscopic site infection that we found in 1994. With absolutely active debridement and source control, we were able to cure all the patients that actually had got this Mycobacterium cheloni from us. Next slide. Now I'm going to tell you how we prevent it, because this is really, really important. So in the OT, we have strict protocols: wipe with wet gauze, dismantle, we immerse in proteolytic enzymes, we mechanically clean all hand instruments with a water jet. In the CSSD, we first soak with an enzymatic solution. And then we've stopped doing any high-level disinfection for laparoscopic instruments. We only sterilize them. So if they're metal, we autoclave them. And if they're non-autoclavable, we would do ETO to sterilize them. Next slide. This is another series that we reported, again, many years ago, when we found that patients who had had, stent, who had had a PTCA, they were coming to us with symptoms of anemia and fever. And in one of the patients, we actually grew out these, can you see these gram stain with these kind of organisms? When we did AFB of them, we found that they were actually acid fast. Nobody was suspecting that these could be acid fast organisms. And these patients had PTCA, this is basically angio and angioplasties done in centers across the state of Maharashtra. In this series, we reported 4 patients with intravascular stent-related endocarditis and stent-related, basically the vascular tree was involved. The blood cultures grew M. abscessus and M. cheloni in these patients. And the problem was they were not coming positive because most blood culture systems are discarded after 5 days. So if they didn't grow within 4 to 5 days, they were being discarded. So we have a practice that now all our blood cultures are kept for 7 days. They can be missed on gram stain. Next slide. And this is just to show you the patient, the first patient. This was he had a valve, and this was the excised valve that was, you can see the granuloma. This was a patient, the second patient who had a broken stent in the left LAD. Looking at, can you see the broken stent there? Next slide. And this was the worst because this was an intravascular stent for a renal artery and aortic aneurysm. And as you can see, this huge renal artery abscess, and there was an aortic abscess as well. Next slide. And I'm just going to summarize what happened to these patients. These were all PTA stenting. This was an AVR. This was a stent from the abdominal aorta. All of them grew rapidly growing mycobacteria. Their clinical features were very vague. So no clinician would dream that these patients could have a rapidly growing mycobacteremia. As per our advice, we advised clarithromycin, amikacin, what is usually given. And despite our advice to give only these reagents, clinicians still believe that it must be MTB. So they insisted on adding first line AKT to these drugs. Unfortunately, in this case, that in most mycobacteria, rapidly growing mycobacteria, including laparoscopy, it's source control that is so important. In these cases, the cardiac surgeons refused to operate on them, and all four perished within 6 weeks. Next slide. So it's really an important issue that we have to address in India, because look at the many manifestations of nosocomial RGM. This is post laparoscopy. This is post angioplasty endarteritis. This is a endoscopic stone removal with a DJ stent. And this poor man went to look more handsome and with cosmetic surgery, and he got this on his face. So whether it's herniorrhaphy, mesh repair, whether it's breast implantation surgery, whether it's arthroscopies, whether it's post joint replacement, whether it is even a LSCS, we are seeing this more and more. And it is really important that clinicians understand and ask the lab to look for rapidly growing mycobacteria. Next slide. And so what ails RGM management in TB endemic countries? One is, if the smear is positive or granulomas are seen on biopsy, it's often assumed to be MTB. If it's not identified and accurately, if it's not diagnosed and not identified accurately, management becomes inappropriate. Next slide. And ultimately, remember, like we have spoken right through this seminar, that RGM are common colonizers in tap water. They are getting acquired resistance to disinfectants such as glutaraldehyde. We are increasingly used, because of cost constraints, reusing single-use devices, and we're not sterilizing them. We are using high-level disinfection. So my request is that I don't say we should stop using. In India, we really cannot stop using single-use devices, but we must sterilize them. We must not use high-level disinfection. Next slide. And of course, inappropriate sterilization. Why should LSCS patients who do not have any single-use device, who do not have a scope, get it? It's just improper sterilization. And I think flash sterilization that is resorted to in most hospitals must be stopped. Next slide. I'm just going to quickly just touch on lab diagnosis because Ritu did a great job. Remember, there are limited lab facilities and infrastructure. Some labs only use egg-based media. There is really lack of expertise for accurate diagnosis, and there's lack of awareness as NTM is potential factors. Next slide. And just to show you, this is the lab methods available for macroscopy, phenotypic testing, molecular, or even chromatography. Next. And basically, you have to remember that if the CB-NAT is negative and the smear is positive, you need to suspect NTM. And again, like we stressed, you need to do a MPT64 on anything you grow. We anyway do it to identify MTB, and if it's negative, suspect it. Next slide. We have actually gone to look at, next slide, to doing multi-top for identification, because we found it is so much cheaper. As long as you have the machine, which is one-time cost, it just works out to about 300 rupees for identification. And we've optimized the extraction directly from midget. And this is just a report of one of our MSc students who really believes in it. And today our lab is just doing it all the time. We have over 78 identifications on board in the library. It's cost effective, cheap, and accurate. Next slide. And like Ritu told you, you can identify it from culture. with the CM or the AS. Next slide. Or you can even identify it directly from sample. And now today we're doing an NTM PCR, and we're also looking at this genotype CM directly from sample. Because remember, if a microbiology lab has to be good, it has to be doing stuff directly from sample, so that the clinicians can get some idea that yes, this could be an NTM infection. So if you directly do it from a sample instead of waiting for culture to grow, you're some 7 to 10 to 15 days early. Next slide. And my last bit is actually susceptibility testing for RGM. Now, I think Sharma sir spoke about that this is not really done too often, and he's right. The reason is, next slide. These are the guidelines that you can go through. These are the clinical infectious disease guidelines that were published for treatment and the consensus management recommendations for the less common NTM pulmonary disease. Next slide. So what do? We do RGM, rapidly growing Mycobacterium phenotypic DST from culture plates, but it's not enough just knowing the MIC, as I'll tell you in a minute. Next slide. Now this is how it looks. We do the RGM, and this is how the colonies appear in the PMD plates. Next slide. Now just 1 minute on basic microbiology. All microbiologists know three words in susceptibility testing. One is the ECOG, which is the epidemiological cutoff, which is the highest MIC of a viral strain. And then there's the PK/PD cutoff, which is the highest MIC that can reliably kill at maximal optimized dosing. So if you dose well, you have the PK/PD cutoff. And the clinical breakpoint is set by these organizations, either CLSI, UCAST. It is set to categorize isolates as S, I, and R, basically on basis of clinical outcome studies. And ideally, the clinical breakpoint should be in this zone of treatability, as you can see here. Next slide. Now, this is a great reference that all of you should read because it's talking about clinical breakpoints for non-tuberculous mycobacteria, especially for avium and abscesses. Now, if you look clearly, this is showing the CLSI breakpoints here. CLSI has actually put out breakpoints, and these are the UCAST, which has not put out clinical breakpoints. They put out PK/PD breakpoints. So if you remember my last slide, there was the clinical breakpoint should be between the ECOF and the PK/PD. But regrettably, the CLSI breakpoints that have been set, these are breakpoints. They have not done it on, they have really done it on limited data in terms of ECOFs, PK/PD, and clinical outcomes. And sadly, because of this, we are seeing a lot of discrepancies with our phenotypic testing, of phenotypic DST testing. So if you see here, next slide. Next slide. Yeah, this is showing you moxiflox, basically DST for moxiflox. And look closely here. This is the NTM breakpoint for Mycobacterium abscesses, that is a rapidly growing mycobacteria. And this is the PK/PD break. Remember from that chart I showed you, the breakpoint should be below the PK/PD, shouldn't be higher. And if you look at the moxifloxacin breakpoints, they are 1. The CLSI breakpoints are less than 1. And the UCAS breakpoints are less than 0.25, indicating less chance of success. And more important, more and more we are finding, I don't want to get into the AUC to MIC because theoretically the PK/PD target is 102 for Mycobacterium abscesses. And at a mean dose of 400, we are barely achieving 20 to 40. So with increasing resistance, moxifloxacin is not a great drug to give for RGM. Next slide. And similarly, even for linezolid, which is a good drug to give, but we need to know that again we have the same problem that the UCAS PK/PD is less than 2. It's lower than the CLSI breakpoint of 8. And we're using linezolid a lot for TB, but the breakpoint for TB is 1. Look how high it is for abscesses. And if you want to achieve the AUC concentrations, believe me, the toxicity of linezolid really succumbs to that. Next slide. This is the last bit on which I'm going to just talk about. The mainstay of treatment for RGM is the macrolides. And you can either have mutational resistance with the RRL gene, or you have an inducible resistance, which means when you're doing a phenotypic testing, you must do incubate up to 14 days. Next slide. And this is why you have to speciate. Remember, we were talking about, even Ritu spoke about it. You have M. abscesses complex. M. abscesses consists of M. abscesses subspecies abscesses. Next slide. And you have M. abscess subspecies abscesses, M. abscess subspecies bulleti, and M. abscess subspecies macillians. Usually, because of a dysfunctional gene, which is the inducible gene, when it's macillians, you have no problem because macrolides will not be resistant this way. But today, 80% of our abscesses, subspecies abscesses, are inducible resistance, and all the bulleti are resistant to macrolides. So we have to remember that if we are seeing this increasingly important Mycobacteria M. abscesses complex in our clinical samples, we must subspeciate to know what we can predict for our treatment for our patients. Thank you. Thank you. This is my last.
Okay. Thank you very much, Dr. Camilla. It was excellent.